Welcome back to the deep dive. Today we're heading straight into the ICU for a look at a pretty high stakes weapon in the antibiotic arsenal.
Yeah, we're talking about Ceftazidime Avibactam.
Right, also known by the trade name Zevicefta. And this isn't your standard everyday prescription. This is really heavy artillery for the resistance era.
It really is. I mean,
Yeah.
it's the definition of a precision tool. We're basing this deep dive on some highly technical medical slides that go into its pharmacology, dosing, and clinical trial results.
So our mission today is to unpack exactly why this specific combination, a third-generation cephalosporin plus a beta-lactamase inhibitor, is such a game changer for ICU doctors.
Especially when they're backed into a corner by resistant bacteria like CRE.
Exactly. So let's break down the mechanics, the sort of dynamic duo here. You have ceftazidime, the antibiotic. On its own, it's a classic, but frankly, it's been losing the war against modern superbugs.
Right, because the bacteria just chew it up.
They just chew it up.
And that destruction is caused by beta-lactamase enzymes. So the manufacturers added avibactam, which is not an antibiotic.
It's a shield.
It's a bodyguard, yeah. It inhibits those destructive enzymes. Specifically, it targets KPC, OXA48, ESBL, and AMPC, which basically clears the path for the ceftazidime to actually do its job.
But looking at these slides, it's clear this protection isn't universal. There is a massive blind spot here.
A huge gap in the armor.
Right. The metallo-beta-lactamases, specifically the NDM producers.
That's a really critical distinction for you to understand. If your patient's infection is driven by NDM enzymes, this drug alone will fail. The mechanism just does not engage.
Unless you get a bit creative. The protocol actually highlights a specific workaround where you combine this with aztreonam.
Yeah, simultaneous aztreonam, usually 2 grams 3 times a day.
Right. To bridge that NDM gap. It's a fascinating bit of chemistry, mixing two drugs so they cover each other's blind spots.
It's a totally viable strategy for NDM. But we also have to be clear about what else Zevicefta misses completely.
Yeah.
It has zero activity against gram-positives, anaerobes, or, and this is crucial, Acinetobacter baumannii.
That exclusion list is vital. Using this drug blindly against the wrong bugs is downright dangerous.
Very dangerous.
And that danger extends to how the body actually handles the drug, right?
Yeah.
Like the dosing.
Right, the standard dose is 2.5 grams 3 AV 3 times daily. But because it is excreted almost entirely unchanged by the kidneys, the risk of accumulation is huge.
If kidney function drops and creates a bottleneck, the drug levels spike. You can't just eyeball the adjustment here. The sliding scale they provide for creatinine clearance is super aggressive.
Oh, absolutely.
I mean, if clearance drops to between 30 and 16 milliliters per minute, you're cutting the dose all the way down to just 1 gram every 24 hours.
You have to be that aggressive. If you ignore that clearance window and the drug accumulates, you risk serious neurotoxicity.
And seizures, right?
Yes. The slides note a distinct potential for seizures in renal patients who aren't dose-adjusted properly, along with other side effects like hypersensitivity and pseudomembranous colitis.
So we have a highly potent drug, very specific target list, and a narrow therapeutic window for renal patients. But when we look at the clinical evidence, it really does hold up.
It does. The RECLAIM trial for intra-abdominal infections, RECAPTURE for UDAs, and REPROVE for hospital-acquired pneumonia, they all showed it was non-inferior to standard carbapenems like meropenem or imipenem cilastatin.
But then there's the warning.
Yes, the credible CR trial from 2019.
That trial threw up a major red flag regarding that Acinetobacter blind spot we talked about earlier.
Exactly. While the drug was mostly effective elsewhere, mortality was actually higher in the Acinetobacter arm. It validated the pharmacology in the worst possible way.
Because the drug just doesn't bind there.
It doesn't bind, and that's a stark reminder, especially in places with high CRE burdens like Indian ICUs, which the slides specifically call out. You simply cannot use this empirically if Acinetobacter is on your suspect list.
Which really brings us back to our central theme. Since Ceftazidime Avibactam works wonders on KPC but completely fails on NDM or Acinetobacter, this precision tool is only as good as your diagnosis.
That is the big takeaway here.
So I want to leave you with this thought.
Yeah.
If hanging this IV bag without knowing the exact genetic profile of the bug is basically gambling, doesn't that make rapid genetic testing in hospitals just as important as the drug itself?
Something to think about for sure.
Definitely. Thanks for diving in with us.